Prostate cancer diagnosis and treatment remains one of the most controversial areas in men's health today. It is the most common cancer diagnosed in Australian men, and there will be 18,000 new prostate cancer diagnoses this year alone. Unfortunately, there will also be approximately 3,500 deaths from prostate cancer this year. First of all, it's important to realise that not all prostate cancers are lethal. Many are indolent, slow-growing tumours that patients will die with rather than from. A recent study called the PROTECT trial from the UK, published in the New England Journal of Medicine, demonstrated that for patients with the lowest grade of prostate cancer, also called Gleason 6, that the mortality rate from prostate cancer in the first 10 years is only 1%. And importantly, there was no difference in mortality between patients who had surgery or radiotherapy and those that had no definitive treatment, and instead were watched very carefully, something called active surveillance. Longer follow-up for this trial is needed, but it is generally accepted amongst urologists and radiation oncologists that most men with a small amount of low-grade prostate cancer do not require any immediate treatment. So we are not going to save lives by treating Gleason 6 prostate cancer. We are going to save lives by identifying and treating men who have Gleason 7, 8, 9 or 10 disease. Because prostate cancer does not cause any symptoms until it is very advanced, the only way to identify these intermediate and high-risk cancers, which do require treatment, is for men to undergo screening in the form of the PSA test and digital rectal examination. The largest randomized study on PSA screening published 13-year follow-up data in The Lancet and found a 27% reduction in prostate cancer mortality in patients who were offered screening. So there is no doubt that screening saves lives and should be discussed with patients starting at the age of 50, unless there is a strong family history, in which case screening should begin earlier at the age of 40. A PSA elevation is not always due to prostate cancer. Other reasons the PSA may rise include benign enlargement of the prostate, infection of the prostate, instrumentation or catheterization of the urinary tract, and even things like bike riding and ejaculation can cause the PSA to go up. So these things need to be considered before embarking on further investigations of the prostate. If there is enough concern that a PSA rise could be due to prostate cancer, or if there is a suspicious lump on the prostate with the finger test, then a biopsy of the prostate is required. A biopsy involves putting small needles into the prostate to collect tissue for pathological assessment. Although a minor operation, it is not without possible side effects, which include bleeding, urinary retention, and infection. And infection is the most serious complication that can occur following a biopsy. However, is now quite infrequent, as urologists in general have moved towards a transperineal biopsy approach, where the biopsy needles travel through the skin rather than through the rectum. MRI of the prostate is not absolutely necessary in the evaluation of men with an elevated PSA. However, it can be very useful to improve the accuracy of prostate biopsy, as lesions seen on MRI can be targeted with the biopsy needles. It is also beneficial for planning a patient's surgery if they are found to have prostate cancer. Information on the MRI, such as tumour location, extension of the tumour outside the prostate, and relationship to the nerves for erections, are important considerations to provide bespoke surgery for individual patients. MRI is also quite useful when patients have had multiple negative biopsies but their PSA continues to rise. If the biopsy picks up prostate cancer, the next step may be to perform some additional tests called staging scans. These tests are performed to identify any spread of the cancer outside the prostate and might include CT scan, bone scan, or a special nuclear scan called a PSMA PET scan. These additional tests are not always required, depending on how aggressive the cancer is on biopsy. The higher grade the cancer on biopsy and the higher the PSA, the more important these staging scans are. Patients who have low-grade disease are best managed with active surveillance, as this will avoid the morbidity associated with treatment. However, in patients with more aggressive cancer, definitive therapy in the form of either surgery or radiotherapy should be offered. The decision between surgery and radiotherapy is also quite controversial, and patients should ideally discuss the pros and cons of each of these modalities with their treating specialists. Robotic surgery using the Da Vinci Xi robot is the most advanced method to remove the prostate in men with cancer. The only randomized study comparing robotic and open prostate surgery demonstrated superior outcomes in the robotic surgery group in terms of less blood loss, less complications, less pain, shorter hospital stay, and better quality of life compared to those patients undergoing open surgery. However, importantly, there was no difference in cancer outcomes, continence, or erectile function between the robotic and open surgery groups. Longer patient follow-up for this trial is required. However, when choosing a surgeon to perform your radical prostatectomy, it is important to look at their training, their volumes, and their outcomes, rather than focusing on whether they perform the surgery robotically or open. Erectile dysfunction and incontinence are the two functional complications that can occur after prostate surgery. At Royal Prince Alfred Hospital and the Chris O'Brien Lifehouse, we have pioneered novel techniques to maximise potency and continence after prostate surgery. To preserve potency, we are using intraoperative Doppler to ensure preservation of the prostatic artery along with the nerves in the neurovascular bundle, which has improved postoperative recovery of erectile function. In order to maximise postoperative continence, we have developed a new technique called the RoboSling. This incorporates a vascularized flap of peritoneum behind the bladder and urethra and is used as a sling to support the anastomosis. This has led to a much earlier return to full continence, and patients are quite often completely continent immediately after their surgery and catheter removal. Prostate cancer diagnosis and treatment is not black and white. There remain many areas of controversy. We know that screening saves lives. However, this needs to be balanced with the knowledge that with screening, we will diagnose patients who do not need immediate treatment and may never require any treatment for their prostate cancer. On the other hand, without screening, there is no way to identify patients with lethal cancers at a stage that they are still curable. So the most important take-home message is that patients need to be well informed about screening, well informed about their treatment options if they do have cancer. And in this way, we can achieve the best oncological and functional outcomes for our patients.